Okay, I think we'll get started. Hello, everyone. Welcome to the Pressure Injuries Learning Series, Session 1, Increased Awareness. My name is Marianne Darpino, and I've had the privilege of working alongside Patients for Patient Safety Canada for over a decade, and I am so delighted to be your moderator today. I'm joining you from Bolton, Ontario, land to many First Nations peoples, including the Huron-Wendat, Haudenosaunee, and the Anishinaabeg, and most recently, the Mississaugas of the Credit First Nations. And I would encourage all of you to use the chat to acknowledge the land from which you are joining us today. This session is being hosted by Patients for Patient Safety Canada with supports and evidence-based resources from Wounds Canada and the Registered Nurses Association of Ontario, and we are grateful for their enduring support. Patients for Patient Safety Canada is the recognized voice of patients, caregivers, and families in Canada and around the world that bring collective healthcare experiences to improve patient safety at all levels of the healthcare system. Patients for Patient Safety Canada acknowledges the unique and valuable perspectives of healthcare providers, leaders, policymakers, and managers of healthcare organizations across all healthcare sectors. By working in partnership, we help to ensure that patient safety decisions, actions, and initiatives are truly patient-centered and result in safe care. Our strength in sharing our experiences allows stakeholders to meaningfully engage with us and work together to ensure we make meaningful impact toward our vision for every patient safe. We're hosting 2 sessions about pressure injuries in honor of World Patient Safety Day this Sunday, September 17th, and Canadian Patient Safety Week in October. There are 2 sessions in this learning series. Our goal for the first session is to share diverse experiences and raise awareness of pressure injuries. Our goal for the second session will be to inform, share, discuss resources to help empower patients and families to prevent and manage pressure injuries. We wish to be as inclusive as possible and reach as many patients, families, and other care providers, and to help bring attention to this important issue. The recording of this presentation will be available, and we ask your help to raise awareness by distributing and sharing this knowledge within your network. The link for this Google slide presentation will be available in the chat, and at the end of the presentation today, the web links are underlined so you can click them for more information. I have one housekeeping item for you. As we will be playing videos throughout the presentation, I ask that you double check your own speakers to ensure your volume is turned up. And now it is my pleasure to introduce Yvonne Marco, member of Patients for Patient Safety Canada and co-chair of the Knowledge Translation Working Group. Over to you, Yvonne.
Wonderful. Thank you, Marianne. Hi, everyone. I'm Yvonne from Patients for Patient Safety Canada. I just wanted to let everyone know that I do have a paralyzed vocal cord, so my voice will go in and out and be a little bit goofy, but I really want to do my best for you guys today, so I hope all goes well. In this session, we wish to share our experiences about how these preventable injuries occurred in order to raise awareness of this important issue. In doing so, we hope to support patients and caregivers with information and skills to help reduce suffering and save lives. Today is about bringing awareness and attention to this important issue affecting vulnerable patients in honor of the World Health Organization's World Patient Safety Day. In the second session on October 25th at 11 p.m. Central, we wish to discuss prevention and other important resources. Many families state they wish they would have known about pressure injuries and how severe they can be. Today, we'll discuss what to look for and talk about the terrible impacts of pressure injuries on our loved ones. It's time to ensure that pressure injury prevention becomes a critical component of all aspects of safe patient care. Prevention is key to minimize harm. To make sure that we're all on the same page, we would first like to explain what is a pressure injury and how does it occur. Pressure injuries or ulcers, also formerly known as bed sores, are caused by constant pressure to an area. The pressure cuts off blood circulation, causing a loss of oxygen and nutrition to the area. This damages the skin and tissues, creating an injury. For those who are severely ill and in a vulnerable condition, pressure ulcers can develop quickly. For example, in susceptible people, a full thickness pressure ulcer can sometimes develop in just 1 or 2 hours, and in some cases, the damage will only become apparent a few days after the injury has occurred. A good tip is to remain vigilant and act quickly to minimize harm. Unfortunately, even with the highest standards of care, it's not always possible to prevent pressure injuries. For example, in intense motor vehicle injuries with possible spinal cord involvement, patients may need to lay immobilized on hard stretchers in emergency and again in surgery. However, for most cases, prevention and minimization of risk and early detection are key to prevention or worsening of pressure injuries. It's important to know common locations of injuries in order to assess and find them before they become deep. They usually occur over bony areas, such as your sit bones or your pelvis, hips, lower back, elbows, knees, shoulders, and head. They can also occur in places where the skin folds over on itself or where there's equipment or medical devices. They occur when you lie in bed or sit in one position for a long time. It can happen much more quickly when the health of your skin is affected by problems like hard surfaces, poor nutrition, or a disease that affects your blood circulation. This can occur to anyone who doesn't move in any age range. Even infants can develop them if they lie in one position for too long. As you can see, many of the body locations identified are private. Families would not typically lift up the sheets and have a look, and may feel even less inclined in the hospital or other care facilities. We will further discuss having safety conversations along with risk minimization in the next session. Understanding the severity of wounds is important because understanding the situation and collaboration matters greatly to us. Pressure injuries are graded in severity from an early stage 1 to a late stage 4. It's also critically important to know the early warning signs and what to look for. So let's talk about the first abnormality, which is a stage 1 injury. Stage 1 begins with a reddened or purple area that remains reddened or dark when pressed. This area may be painful, firm, soft, warmer, or cooler than the surrounding skin. Good tip is to please let the patient know to notify of any discomfort, not to dismiss it, so that the sore area can be checked. Stage 2 is an open wound with pink or red at the bottom layer. Stage 3 is complete skin loss down to the fatty layer. Stage 4 is complete skin and fat loss down to the bone, tendon, or muscle. Unstageable is when the wound is covered and the depth cannot be determined. A stable scab can serve as a natural cover. A good tip is to keep this dry. Next, we'll show examples of real wounds, so please take precautions for sensitive viewers. So, what do pressure injuries really look like? Here we have examples of the early stage 1 and the late stage 4 wounds on darkly and lightly pigmented skin. It can be tricky to find them since they commonly occur on the bottom surface of the body or on private areas, and they are difficult to see on darkly pigmented skin. In fact, patients with darkly pigmented skin suffer from full thickness pressure injuries at a higher rate than patients with lighter skin due to the lack of early recognition. As a result, these patients experience poorer outcomes. Often, bedside teams did not recognize the early subtle warning system signs of pressure injuries until the overlying skin begins to slough and fall off. A tip is that moistening darkly pigmented skin assists with identifying changes in color. On darkly pigmented skin, look for a purple or blue color. As you can see from the images of the stage 4 injuries, they can become very, very serious. They're large, deep, painful wounds and life-threatening due to infection and kidney failure. In Canada, 60% of elderly patients with a pressure wound will die within 1 year of discharge from the hospital. Each year in the US, nearly 60,000 people die because of complications associated with pressure wounds. All stages of pressure wounds are prone to complications, but especially stage 3 and stage 4. These complications include cellulitis, osteomyelitis, necrotizing fasciitis, also known as flesh-eating disease, gas gangrene, and septicemia. Next, we'll listen to the impacts of these wounds on patients. Over a period of 3 years, Kathy's father developed recurring pressure injuries during his stays in hospital. During these times, he was not able to move unassisted. In this story, Kathy shares the impact of pressure ulcers on her father's health and quality of life in his final years. This story demonstrates the importance of understanding the severity of pressure injuries and that they can be prevented through regular positioning. The video plays quietly, so please increase the volume for sound. This is Kathy's story.
My dad was always very physically active, despite having suffered a back injury from a mining accident at the age of 23. This left him with chronic back pain, but he still was able to work on the railway and the farm. My mom, sisters, and I could tell he was in pain, although he never complained. Dad and Mom were always independent, and they stayed on the farm as long as they could, but eventually Parkinson's affected Dad enough that they had to move into the city. The first time he was admitted to the hospital was when he had pneumonia. Over those 2 weeks, he didn't get out of bed much at all and started to complain about back pain. It wasn't until he arrived back home that we saw the quarter-sized weeping open wound on his spine. The home care nurse confirmed that it was a pressure ulcer resulting from being in one position too long. The bony part of his spine from the accident years before had increased the pressure in that one spot and broken the skin. With the care of the home care nurse every day, it still took months to heal and for the pain to be managed. The second time he was admitted to the hospital was a year later. He had fallen and broke his femur, which required surgery. He spent another 2 weeks in the hospital, and after being transported home again, we found that the original pressure ulcer reopened and was even bigger. We understood that it could be hard to reposition someone who had a broken femur, but at the same time, we knew he was supposed to be moving around as part of his physiotherapy. How could this have happened again? The staff at his long-term care facility did all they could to make him comfortable, turning him often in bed, placing pillows around him, using a special donut made for his back when he sat up, and giving him medications for his pain. But this time, the ulcer also required visits to the wound care clinic for debriding and bandaging. It took almost a year for the skin to heal again. The final time he was admitted to the hospital for pneumonia, we were nervous. For the first few days, we couldn't visit because of the COVID protocols, and one nurse said he would make sure the pressure wound wouldn't open again. The rules changed after a week to allow families to visit, and we discovered that his pressure ulcer had reopened again. We were beside ourselves. I said, Dad, why didn't you ask them to turn you? They seem so busy, he said. I didn't want to bother them. We decided that we would take turns to be with him every day and to reposition him ourselves. We knew what to do after the first 2 times, but the wound was so big, turning him made him scream in pain. Dad insisted he wanted to go home, and after 2 weeks, we discharged him ourselves. That pressure wound never healed. It was the size of my fist at one point, and it smelled terrible. The long-term care staff took good care of Dad, made the time to keep us informed, and addressed our concerns. He lived for another 2 months, and like always, he never complained much, even when we knew he was in pain. Looking back, it is hard for me to come to terms with the preventable pain that he had endured. A few minutes every hour or two could have entirely changed the last 3 years of my dad's life. And that is why I am sharing our story.
Thank you, Kathy, for sharing your story with us. We would like to ask you to reflect about Kathy's story and ask yourself, what resonates with you about Kathy's story? After watching the story, what does the title Avoidable Pressures mean to you? What are the impacts of a pressure injury on both a patient and their support persons? How could you partner with patients or support persons to ensure that pressure injuries do not occur? We'd like for you to wait until the end of the presentation so we could share our thoughts and questions together. It's sad that many families state they wish they would have known about the risks. It's time to ensure that pressure injury prevention becomes a critical component of all aspects of safe patient care. We know that our healthcare system is under strain, but ask if improvements and efficiencies can be found. Prevention is key because we know that 70% of pressure injuries all are preventable. In a 2003 study founded by the Canadian Association of Wound Care, the overall prevalence of pressure injuries across all healthcare settings was 26%, with approximately 70% of those wounds considered preventable. Prevention is of paramount importance and must be the focus of care for all patients and across all care settings. Next, we will have Kim tell her story. Kim shares with us her reflections on pressure injuries as a nurse and with her father, who experienced paralysis on his lower body due to cancer. This is Kim's story.
Hello everyone, and welcome to our webinar on pressure injury. As a nurse, long-term retired nurse, I've seen all stages of pressure injury. I've seen their treatment, and when I try to conjure up these images in my mind, really only three sort of have stuck with me all of these years. The first one is when I was 19 years old. I suppose I was somewhat impressionable, and I was a nurse's aide in a long-term care facility. Sunlight bar soap was the skin protectant that was used, and it was rubbed onto all of those reddened areas. Now that would be defined as stage 1 pressure injury. Stage 2 and 3 were treated by exposing the buttock to a window with the sunlight streaming in. At the end of the summer, what I recall is that are these images of very tanned buttocks and healed ulcers. And the second image that comes to mind, who I recall, is a very pale person, a bit obese, but nutritionally depleted, with very badly decomposed buttocks. Probably the worst I've seen. And in this case, the patient tried to manage his situation at home and was not successful. And then I remember my father's wound, and it was almost as large. And when this image comes to mind, it's accompanied by the thought that there are some things that a daughter should not see, even as a nurse. Dad loved life. He was highly energetic, a hard-working farmer, and a gifted old-time dancer. His legs were everything. They were powerful, with rock-solid calves. And then, all of a sudden, his legs started to fail him, and he was falling. A cancerous tumor was diagnosed in the lower part of his spine, and he was operated on 3 times. And after each surgery, he miraculously walked again and did everything he loved to do. After the 3rd spinal surgery, his dedicated surgeon was very emotional when he told Dad that he would not be able to operate on him a 4th time and that he would be paralyzed from the waist down. I mention this because healthcare workers cared deeply about Dad at every stage of his treatment and through his death. Compassion was always present through his care. The tumor returned as predicted, and Dad spent his final months in palliative long-term care. He was paralyzed from the waist down. He had no control of his bowels or his bladder, and he had no lower body sensation. Each week he became more thin and more yellow. And I assumed that Dad would be devastated and depressed about his situation, but his zest for life continued. He focused on what he had, and he disregarded all of the rest. He really seemed blind to the lower part of his body. It was like it didn't exist, and he ignored it. All of this, of course, were challenges and created all of the risks for pressure injuries. A nurse pulled me aside one day, and she didn't hide her deep concern. "We can't get your dad to lie down," she said. "He wants to sit in the wheelchair all of the time, and he's developing a very bad pressure ulcer on his buttocks." Dad, he wanted to live every remaining moment upright. He wanted to be engaged in everyone and everything around him. And he jokingly said, "I have a lot of time ahead where I'm going to have to lie down." Current literature speaks of unavoidable pressure injury, and I think that's what Dad had. He had a special mattress, he had a wheelchair cushion, he had a Foley catheter to keep him dry, and the staff did their best to relieve pressure injuries. But Dad was faced with internal as well as external destructive forces. He could not beat the devastation of cancer, even though he had many positive social determinants of his health. I'm challenged now today to think about how stage 4 pressure injury could have been prevented in his situation while still honoring his wishes. I think about, well, what about if family were cared for Dad at home? Would he have been more relaxed and less inclined to be upright and ready for visitors? What if sensors could detect bowel actions so that feces was removed immediately and not there to caustically erode at his skin? What if skin protectants were really highly effective barriers and not just barriers? And what if he could have rested comfortably on his stomach for the night, or gently somehow rotated mechanically? And what if his wheelchair was ergonomically designed to distribute his weight completely differently? And what if pressure areas were implanted with silicone or with fat? These are the kinds of things that seem possibly reachable. Pressure injury can be incredibly stubborn to treat, and my hope is that families will become part of the prevention plan and that more research into innovations will also be realized. Thank you very much for listening.
Thank you, Kim, for sharing your story with us. We'd like to please reflect about Kim's suggestions to prevent pressure injuries, especially about involving more innovations or increasing the involvement of families. Next, we would like to address a very important issue, which is the specific individual context for patients. Patient safety is a holistic issue, and individualized solutions must be found. Canada is one of the healthiest and most diverse countries in the world. However, some Canadians are healthier and have more opportunities to lead a healthy life. Understanding factors why some people get pressure injuries and why some don't, and root out some of the causes and inequities in care. While pressure injuries are obviously influenced by physical and environmental factors, we would also like to take a moment to step back and take a broader, more holistic view. If we really want to address the true cause of pressure injuries, we may need to work on other factors, such as the social influences. The social determinants of health can have important and invisible influences on health. They are the broad range of personal, social, economic, and environmental factors that determine a patient's health, such as their social status, their income, education, or employment. Experiences of discrimination, racism, and historical trauma can be important social determinants of health for minorities such as Indigenous people, to SLGBTQA+, and people with English as a second language. These power imbalances affect patient understanding, safety, and rights. Our goal is that attention is brought to the impacts of the social determinants of health on care and the removal of barriers for accessing care. We also wish to emphasize the important goal of inclusiveness. We all want to be respected and acknowledged as equal human beings. As well, we request that care given is aware of health inequities and is patient-focused. The main determinants of health include income and social status, employment and working conditions, education and literacy, childhood trauma and mental health, physical environments, social supports and coping skills, healthy behaviors, access to health services, race, gender, culture, and genetics. Healthcare in Canada is paid by taxpayers. The amount of money for healthcare is limited, and understanding how much is spent on healing pressure injuries, which are mostly preventable, is important to us. Pressure injuries can cause a longer stay in hospital and increased healthcare costs. There's not a lot of current information about this, and what we found is from 10 years ago. But you can see that 15% of elderly patients will develop pressure injuries within the first week of hospitalization. Costs to treat pressure injuries that were present prior to admission ranged from $11,000 to $18,500. However, hospital-acquired pressure injury treatments ranged from $44,000 to $90,000 for stage 4 wounds. The average cost of care in hospital was $24,000. Home care costs about $9,000 a month for pressure injuries. We would like to pause here and bring to attention that not all expenses are covered for those being cared for at home, and costs beyond those mentioned can occur. Patients who are economically disadvantaged may not have access to all the supports available. The challenge is to consider all the variables at all the levels of the system and work to bridge gaps to improve the quality of care for every patient. We support the reduction of health inequities. Reducing health inequities means helping to give everyone the same opportunities to be healthy, no matter who they are or where they live. All of us need to be aware of these invisible forces and work towards better health for all Canadians. For example, we need to address hidden biases and stigmas to people who are disabled. Poverty, which includes the lack of resources and choices patients have. Exclusion of people who are mentally ill or have experienced trauma. And low health literacy for those who don't understand the risks and harms of pressure injuries. We would also like to briefly discuss emphasizing care that is patient-centered and culturally sensitive. Care providers should strive to keep the patient's needs and perspectives at heart, contributing in a way that tries to prioritize the needs of the patient. All patients have their own particular contexts and social relationships. These might impact how to best interpret their preferences and well-being. Healthcare providers should respect the informed, voluntary wishes of patients. Any decisions should be mutually agreed upon by the patient and their circle of care. Collaboration is key. Next, we will have Genevieve tell her story. And now we'll hear from Genevieve.
I'd unmute. Hi, everyone. My name's Genevieve. And I want to tell you about my Auntie Carolyn. My Auntie Carolyn was diagnosed with multiple mental health issues before the age of 25. She was lived on government assistance, disability her entire life. She lived with my family for most of my childhood, and when our family dissolved, she met a man who she got married to who had a brain injury, and he's consistent as a 14-year-old boy, even though he's an older man now. She took care of the finances and took care of what was needed in the home, and he provided emotional support and companionship, and they were quite happy together for many years. They moved close to her mom, my grandma, for support and help, and they lived in the same apartment building, which was great. When grandma died, my aunt's delusions increased. She had delusions throughout her life, but without her mom kind of stabilizing things, stabilizing her decision making, my aunt gave notice at their rent controlled apartment, and her and her husband were one day from being homeless before the church group that they were involved with found them a place in assisted living. Now, my aunt and my uncle were in their early 50s when that happened. And so living with people who were usually about 30 years older than them. And so they had a hard time connecting with folks. But they lived there for a few years, was away from anybody that they knew, about an hour away drive in rural Ontario, but that was the only place that they had found a place to live. They qualified for assisted living because of my uncle's brain injury and him unable to take care of himself. And my aunt was able to join him. Because assisted living doesn't provide any medical support, you have to find that outside of the assisted living setting. At one point, her diabetes became not managed well, according to the nursing staff at the assisted living residence. And so she was transported to a long-term care facility just about an hour away from her husband. And she was in that long-term care facility with no one visiting. She had no family doctor in that area. And there she developed a pressure injury. The long-term care facility decided at, I think it was about 4 months after she'd been there, that the pressure injury was too bad, and they sent her to the hospital just down the street. And at that point, I became her medical decision maker because her husband didn't have the capacity to do that. And unfortunately, because I live in British Columbia, I wasn't able to be there at the be there in a way that I felt was more meaningful than what I was able to do. So my aunt's in this hospital and her husband's unable to visit because he can't drive. There's no community bus service. And her delusions were just increasing and increasing, and to the point where she wouldn't accept phone calls. She lived in an alternate reality. And the pressure sore had developed into sepsis, and she was refusing care. And at that point, after about a week of talking with the doctor on the unit, I agreed with my aunt's decision to stop treatment. And she subsequently died at age 59 in the hospital, in a rural hospital in Ontario. I miss her. And I miss that she didn't have anyone with her when she died. And I feel like she was let down a lot in life. Speaking about those social determinants of health, poverty being one of them. I don't know if folks here understand, but if you're on Canada Pension Disability and you meet a partner, your joint income is your joint payment is less than if you were separated. So actually finding companionship, building a life is a detriment to your ability to have healthy food, to have good housing. Yeah, I just wanted, I really appreciate the opportunity to tell my Auntie Carolyn's story. And I just feel that there's so many points where she was let down. No mental health support in the assisted living, long-term care, or the hospital. And ultimately her wishes were were granted, I guess. But yeah, she was a loving person, and I wish that she didn't have to die in that way. So thank you for listening, and sorry for such a sad story, but she was a lovely person, and thank you.
Thank you so much, Genevieve, for sharing that very intimate story of your aunt. Okay, so to make it easier for you to check out the sources we've used and to find more detailed information, we've included the links for this Google slide presentation in the chat. You can open the link and find in the presentation everything that's underlined a link, or you can go to this slide and find it all together here for your convenience. As well, as World Patient Safety Day approaches on September 17th, there is a blog story available as well from Alice Maybe from the Patient Advisors Network, Katerina Kovacs Burns from Patients for Patient Safety Canada, and Adrienne Zaram from Healthcare Excellence Canada. They reflect on the vital role of patient partners that play in the safety of healthcare. And read the story, and there's a link right there for you. We would especially like to thank the volunteers who shared their stories with us, my co-chair Paula, and the many wonderful hands that helped to create this presentation. We thank you so much for your time. We hope to have connected with you in order for you to remember the impact of pressure injuries on our loved ones, and perhaps persuaded you a little to help us work together toward creating improvements to patient safety and the reduction of pressure injuries. We have the following call to action. For patients, families, and caregivers, become aware about the risks and skills to manage or prevent pressure injuries. Increase awareness of contacts and resources that are available to help. Notice what is happening and gather information. Get involved and act quickly about the degree, get involved and act quickly in prevention and management of pressure injuries. Please have an honest, respectful conversation about the degree you want to be involved. Seek guidance from healthcare providers about how to be involved, and seek support to build resilience and prevent burnout. Advocate and share your voice to bring concerns to the attention of healthcare providers. You have a right to express concerns about your care. As well, consider raising your voice to make improvements for healthcare quality and safety for all patients. We also ask for mandatory reporting and better statistics to be provided to the public. For healthcare providers, proactively prevent and manage pressure injuries. Prevention results in lives saved and reduction of suffering and harm. 70% of pressure injuries are preventable, and prevention is key. Lead the care and collaborate. Take ownership of problems. Collaborate with interprofessionals and families and their caregivers to reduce gaps in healthcare. Promote consistent action with appropriate assessments and quick follow-through with treatments or corrective actions. Educate and coach patients, families, and caregivers to learn the risks and participate in care. They are a valuable member of the team. Focus on patient-centered, culturally sensitive care that is also sensitive to the social determinants of health, and work toward the reduction of health inequities. This includes increasing the empowerment of the patient, caregiver, and family voice. We will be discussing many details of these action items in our next session on October 25th. I hope to see you there, and thank you so much to everyone. I'll hand off next to Marianne.
Thank you so much, Yvonne. I too wanted to especially and sincerely thank Yvonne, Kathy, Genevieve, and Kim for sharing your stories. And I'll also note, and Donna for sharing your note in the chat. It's just such a powerful reminder of the critical importance of patient advocacy. So thank you all so very much. So next, I'm so glad to see that we have some time together at the end here, and we'd love to hear from you. So we had some questions, but really we wanted to make this as interactive as possible. We had some thoughts and inquiries about how pressure ulcers, injuries have or do affect you or have affected your family members. Do you have any particular questions or comments that you'd like to share with us? What resonated with you most about the stories that you heard today? And we invite you to use the Zoom chat box, or please add to this presentation with your comments by using your cell phone camera to scan the QR code, and your comments will actually appear on the slide. So I will just, I realized that I actually didn't have my video on. I'm sorry about that. Here we go. So, and please don't feel shy to just, open up your mic. We're an intimate group today, so we'd love to just hear from you and have a little bit of interactive conversation.
It's Kim, and I'm just going to pick up, Marianne, on something that you just said, and that is don't feel shy. And I think when we accompany our family members, or we are a patient in a healthcare environment, we are a bit shy, right? It's not our territory. And so I think there's that challenge of, how do we check and oversee what's going on under the blankets largely. These kinds of things are kind of hidden to our plain sight. And so, I think one of the things that we have to do is, gain permission from our family member, give permission to our family members if we're the patient, to, check on things, how things are going now that we have this information about what those early stages look like, and even before those early stages develop. So anyway, I've always thought being shy is a little bit of is part of the problem with avoiding pressure injury.
Yeah, absolutely. Very well said. Thank you so much for adding that, Kim. Donna, I see your hand up. Go ahead.
Hi, wonderful session, everybody. And as always, the stories are so impactful. I have two things that I'd like to say. Number one is that, being a nurse for almost 47 years, we have seen where when residents are admitted to long-term care, we have a fall risk that we have to do. And I know in Saskatchewan, we have a wound risk as well. Are they at risk for pressure injuries? Is that common across the country? And if it isn't, perhaps we should be advocating. I know there's a session or push out there right now for long-term care and excellence in long-term care. And maybe that's something we could push for, is that not only do they fill out the form, but they really pay attention to whether or not this person is at risk and is developing a pressure sore. The other thing that I'd like to ask is, what new treatments are there out there? And does anyone know of any new treatments that could be possible? We have a daughter with spina bifida, a very high spina bifida. So she is paralyzed from about mid-chest down. And only through the grace of God has she not experienced pressure sores in all her multiple hospitalizations. And I guess probably due to me being at her bedside and making sure too. But, you know, so that's two things that I'd like to bring to light or to ask about.
Thanks so much for that, Donna. And so I think the first part of your inquiry was around the standardization of screening. Is that correct across the country? Yeah. And then the second one was about any innovative treatments. So I don't particularly have an answer for any of you for that, but I'll open it up. I know that part 2 of this was going to focus more on the treatment side of things. So, you know, if you know, I'll give a minute or so if anybody wants to chime in to your questions, or feel free to write it in the chat box as well. But I think it's also a really critical question to bring forward when we have some folks for the next presentation as well. So thanks.
I can
Does
add
anybody
an
have a
answer. It's Andrea. I'm a practice lead in Alberta, focusing on pressure injury prevention for adult patients in the hospital. And there is an Accreditation Canada requirement for assessment of all patients that come into hospital for pressure injury risk. And depending on that, if patients are at risk, then that has to be repeated. And there is a designated schedule for that. I can't speak specifically to long-term care, but they also have standards in place for that. And I believe so for home care. So there is that risk assessment. What we're seeing locally in Alberta is it doesn't always follow through to doing interventions for patients that are at risk, and we're hoping to change that.
Thanks so much for your reply, Andrea, and for joining us today. I see, Crystal, you had a response to the question. Did you want to just chime in?
Sure, I'm Crystal. I'm the Director of Education at Wounds Canada. So I'm not aware of each individual province and territory's requirements around pressure injury risk assessment in long-term care, but I can speak to Ontario, having worked in long-term care in Ontario. And it sounds very similar to Alberta. In Ontario, yes, absolutely. Upon admission, any change in health, leave of absence, return from hospitalization, quarterly, annually, every long-term person living in long-term care in Ontario has to have a pressure injury risk assessment completed, and then a care plan generated based on that. So, and that is something that's monitored by the Ontario Ministry of Health. So as part of the inspection process, that is monitored and is a requirement. And they actually, there's actually public reporting available on pressure injury incidents and prevalence in long-term care homes in Ontario.
That's great. Thanks so much, Crystal. Thanks for joining us and adding that. And Paula, I think you were up next.
Yeah, I just wanted to say one thing. First, actually, I already put it in the Slido, but I wanted to point out just how big a difference it is when you have extra caregivers coming to the hospital or staying at the house with you when you're getting various treatments. And I also wanted to say I'm glad we focused on the fact that pressure injuries are so, like, people don't want to bring them up because it's embarrassing, and the fact that they're on what are considered like private parts, it makes things so much worse. And I've at least heard this anecdotally before, and I guess what makes it logically would be that a lot of the time the person who stays home for help, who does the caregiving for someone, is often the wife in a heterosexual couple. Just because, especially, and that's even more the case when that person stays home because they are caring for children and so on. So if you have, for example, and I'm just with heterosexual here couple just because statistics are so much higher. And certain, I guess, social roles that are in place. I work, so it can be like, for example, the husband's mother or father, and having it be the daughter-in-law who would be the one taking care of things. That's a huge issue. Obviously, this is just one situation. There's plenty of others, you know, in terms of social roles and everything. But I just wanted to point that out as a particular issue. And I know that, for example, when in my family, it was definitely my mother who stayed home and cared for me, and she was also the caregiver for my Baba, my dad's mother, until we had to get home care because things were just so too much. So I just want to point those out as particular issues, and I'm not really sure where to go in terms of dealing with that, because I mean, it is incredibly private a lot of the time.
Thank you, Paula, for sharing that. And maybe I would just ask if anyone has any comments for Paula, if you could kindly write them in the chat, that would be wonderful. And I'm just looking across the screen. Lori, I think you're up next.
Hi, yeah, I'm brand new, so it's really nice to be here, and this was a fantastic educational meeting for me. I feel like I've just enrolled in a new university program, so yeah, this is great. And I wasn't sure actually when I joined this meeting whether my experience would be helpful, but I think it is. So I'll just tell you a little bit about that very quickly. 8 years ago, I had colorectal cancer, and I had the usual chemo, radiation, surgery, and more chemo. And because they couldn't avoid giving me a colostomy, so they had to deal with removing my anus and rectum and then sewing that up. And a problem that I had actually for 2.5 years was that incision would not close. And that was the result of radiation. As you probably know, radiation doesn't discriminate between cancer cells and healthy cells. So I had a really fragile wound that couldn't support stitches. And I was having sometimes daily, sometimes 3 times a week, nursing care in my home to try to heal the wound, and nothing was working. And I went from doctor to, I'm in London, Ontario, and I went from doctor to doctor to try and figure out, okay, what can I do? What, you know, there must be some answer here. And nobody seemed to have any ideas. And I finally got, I'm not one to like, I turn over every stone looking for an answer. That's just kind of who I am. So I finally I got a referral to a surgeon at Mount Sinai in Toronto, and the first thing he said to me was, "Oh, I think you'd be a good candidate for hyperbaric oxygen therapy." And I said, "Wow, I don't even know what that is." So long story short, I was referred to Hamilton General hyperbaric oxygen therapy, and 6 weeks of daily hyperbaric dives turned my wound around completely. It finally turned pink. It was this sort of, you know, zombie white for 2.5 years. It finally turned pink and it began to heal, and it's healed now for 8 years. But what is upsetting to me is that nobody in London pointed me in that direction, and I went through umpteen doctors. And when I hear, you know, some of the issues that can come from pressure ulcers, you know, I look at the list of things that Health Canada will cover. Well, it's basically that most of the provinces, I think, will cover hyperbaric oxygen for. So Yvonne, you had mentioned osteomyelitis. That's something that the provinces will cover, and gas gangrene is another one that's on that list. And I wonder how many people even are aware of that. For me, you know, I probably went through 8 doctors, you know, total, looking for answers. And it wasn't until I finally got this one doctor who understood about hyperbaric oxygen therapy. So when I spoke to yesterday, actually, I emailed my contact at Hamilton General in hyperbaric medicine, and he says, if we have so few hyperbaric facilities attached to medical schools in Canada, and he said, if you don't train with it, you really don't understand the technology. And then when you get out into practice, you don't really know how this can be helpful, and you're less likely to consider it as a treatment. So, I mean, I guess that's my story there, is maybe that's and I know, you know, we're going to be talking about treatments in the next meeting, but you know, to me, that's kind of a flag that needs to be waved, that here's a possible treatment for, you know, really, you know, bad pressure ulcers that possibly we should be considering that perhaps isn't being considered. So that's all I have to say on that. Thanks so much.
Thank you, Lori, and welcome. So thanks first of all for sharing your story, for persevering, and also reminding us like how important, you know, it is to have family advocacy, but self-advocacy as well. So, I mean, and we're so happy to hear that you've got some treatment now that's working. So that's awesome. And your other point about just raising our collective awareness about those, you know, those treatments that we might want to pick up on the next webinar is really important. So thank you. Thanks so much for sharing that. I'm just going to do a time check. So I see we're a minute over our time, and you know, if folks do need to leave, please by all means do that. I know we had planned for the 1 hour, but I see one hand up, and Eileen, I'd love to give you the last word. So please go ahead.
Thank you. I did put it in the Slido, but I'm hoping, I did work in an organization before I retired, and they did have an assessment at each change of shift. So pressure, they call it pressure ulcers at point, falls, pneumonia, and there should be one last thing I've forgotten, but that was key. So every single shift change, they did have to look under the sheets and check with the patients. So hopefully that will disseminate soon through all the protocols. That's
great. Yes, thank you. Thank you so much for that. All right. Well, I know we could probably stay on for a lot longer, but we're going to bring the webinar to a close. And just on behalf of all of the folks who put their hands in to prepare this webinar in time, to all of you for taking the time to join today. We're really excited to spend this time with you. Thank you for joining, and we look forward to our next session, Learning Session 2, October 25th, and hope to see you all there as well. So be well, and thank you again. Take care and have a good day.
Thank you.
Bye all.
Bye.
Thank you.